Thank you for joining us on our third lecture of the NHRC side presentation. Today, we will be discussing interesting cases in atypical neonatal pulmonary hypertension, and that will be presented by Dr. Mahmoud Montasser. Dr. Montasser is a consultant neonatologist at the University Hospital Heuchan, transport consultant neonatologist at Scottstar Regional Neonatal Transport Team for West Scotland, UK, and honorary clinical senior lecturer at University of Glasgow. Dr. Montasser's main special interests and areas of research are neonatal hemodynamic assessment, cardiopulmonary vascular transition, acute and chronic pulmonary hypertension phenotypes, functional echocardiography, and lung ultrasound as part of focus in neonates. Also, we will be joined by Dr. Neil Patel, who is a consultant neonatologist at the Royal Hospital for Children, Glasgow, a senior NHS Research Scotland Fellow, Scottish Quality and Safety Fellow, and Clinical Innovation Lead for the West of Scotland Innovation Hub. Dr. Patel research focuses on congenital neonatal disease and assessment and treatment of neonatal circulation, and he has a particular interest in pulmonary hypertension in congenital diaphragmatic hernia. Dr. Anne-Marie Heuchan is a consultant in neonatal medicine at Royal Hospital for Children, Glasgow, senior lecturer, University of Glasgow, and executive member of the British Society of Neonatal Hemodynamics and Focus Group. She has areas of interest on research that includes neonatal echocardiography and neonatal hemodynamics, management of PDA in preterm infants, risk factors for prevention for PVH, management of neonatal vein of Galen aneurysmatic malformation, and cerebral nears monitoring and applications in the neonatal unit. And for the panel discussion, we will be joined by Dr. Elaine Neary. Dr. Neary is a consultant neonatologist at the Liverpool Women's Hospital in Liverpool, UK, an honorary clinical lecturer at the University of Liverpool and NIHR research scholar. And also by Dr. Neem Subedar, who is a consultant neonatologist at Liverpool Women's Hospital in Liverpool, UK, and clinical lead for the Cheshire and Merseyside Neonatal Network. Thank you so much, Dr. Montasser.
Thanks, Daniel, for the kind introduction. I would like just to invite my colleague, Dr. Patel, to start, and then will be followed by Dr. Heuchan, and myself will be presenting in the end. Thanks.
Thanks very much, Mahmoud, and thank you very much for the invitation to join you all today. It's a pleasure to be here and to be presenting with my good colleagues, Mahmoud and Anne-Marie. So hopefully this will be enjoyable for everybody else as well. I'm just going to share my screen and hopefully you can see that okay. Can you see that okay? Someone give me a yell if you can't.
Perfect.
Thank you very much. Okay, so I literally just took this photograph actually just to prove to you all that we sometimes do get a little bit of sunshine here in Glasgow. It's been a long winter, so it's nice to see things slightly brightening up with the spring. And that's a view just from our neonatal unit of the Children's Hospital here. I didn't know what to call this case presentation, so I've called it AHA. And hopefully you'll see why that was how I felt at the end of this. So this case that I'd like to present to you all is of a baby that was born prematurely at 24 plus 5 weeks gestation with a background of preterm premature rupture of membranes for a few weeks before delivery. Delivery was by spontaneous preterm labor, but was complicated by placental abruption, and birth weight was 750 grams. Unsurprisingly, baby had significant respiratory distress syndrome in the first days after life, had ventilation and 3 doses of surfactant. And following on from that in the first couple of weeks of life, had a sepsis episode and subsequent sepsis episode that followed on from that as well. And a picture of evolving chronic lung disease. So I want to jump you forward a few weeks to the 43rd day of life, when this baby had a corrected age of 30 plus 5 weeks. And at that point, as I mentioned, they had significant evolving chronic lung disease. They had a couple of unsuccessful extubations on day 35 and then day 41, just a couple of days beforehand, and had received a couple of courses of dexamethasone to try and facilitate extubation associated with those trials. At this point in time, they were one of those patients who you probably all recognize who, because of their lung disease, is on moderate ventilation and moderate amount of oxygen, but is in a fairly kind of chronic holding pattern. You're just hopeful that you can try and make some more progress to work towards them, getting them off the ventilator. And to some extent, they're the patient that kind of tends to sit in the ICU, you know, without acute change, but hopefully slowly making some progress. Their blood gas at that point kind of reflected their status. They had a compensated respiratory acidosis with the numbers that you see there. So this is a patient I inherited on a Sunday morning. Now, the day beforehand, they'd had an X-ray, and it's kind of consistent with that clinical picture. You can see significant chronic lung changes there. And they'd also had an echocardiogram. And you can see here from a short axis parasternal view that they had a moderate sized PDA. And on the Doppler, that showed low velocity, continuous left to right, unrestricted pattern. The long axis parasternal view there shows that there's a little bit of left atrial enlargement. So at this point in time, we were certainly weighing up what the significance of this duct was and whether it was contributing to the ventilator dependency in this patient, and whether this was a duct that would merit treatment either in medical or surgical form to help us make progress. So as I say, that's the patient I inherited on a Sunday. It was actually an extra shift for me. One of my colleagues had COVID, so that was the reason why I was in on that particular day. And when we did the ward round in the morning, we didn't think that much had changed from the kind of subacute course that this patient had already exhibited. At 6 o'clock in the morning, they were still on those kind of modest ventilation pressures, tolerating their feeds well. The gas had shown a little bit more of a respiratory acidosis than normal, but in the context that they were otherwise well, we weren't too concerned about that. However, over the course of the morning, they started to have some frequent desaturations, and they had a one-off temperature. They were pyrexial at 38 degrees. And we repeated a gas at that point, and their CO2 was going up. They had a worsening respiratory acidosis. As a precaution, we cultured them, and we did a CRP that was 12, wasn't particularly elevated, but a little bit up. And because we were feeling a bit cautious, we started antibiotics at that point and repeated the chest X-ray in view of what appeared to be a respiratory deterioration. And certainly there were some new changes on the X-ray. You can see in the right mid and lower zone, there were some patchy changes there at atelectasis. So we did some ET bronchial lavage at that point and had quite a good result. We got quite a lot of secretions up and felt like we'd probably solved the problem and addressed the respiratory deterioration that they'd had over the course of the morning. But over the next few hours, they actually continued to deteriorate, more desaturations, some evolving abdominal distension, and they developed a gap between their core and their peripheral temperature as well. So we increased the ventilation, and because of the abdominal distension, decided to get an abdominal X-ray as well. Remember, this patient had been on full feeds, which were actually fortified as well. Abdominal X-ray wasn't particularly concerning. There's some gaseous distension there, the loops as you see, but obviously the main thing we were looking out for were any changes associated with NEC, and there wasn't anything there to particularly concern us. But things continued to get worse. The patient had ongoing worsening hypoxemia, and their inspired oxygen escalated up to nearly 90%. And their saturations were only just holding in the mid-80s on that. In addition, they started to become hypotensive, with low diastolic pressure, as you see there, and also oliguric. And repeat blood gas showed ongoing respiratory acidosis, despite the changes we'd made, and actually a progressive metabolic component as well to the acidosis. So we got another chest X-ray. We changed to high frequency, and we really escalated the ventilation settings on high frequency. We restarted dexamethasone at a higher dose to treat what we presumed was a partially respiratory exacerbation of chronic lung disease. And as a precaution, we stopped the feeds altogether at that point. And I really hoped, having seen this kind of pattern of ongoing deterioration, that by making those actions, we were going to address the ongoing deterioration at this point. So here's the chest X-ray, and as you can see, those changes that we'd seen earlier in the day had resolved following the ET lavage that we'd done. And this is what was confusing to me, because we were seeing an ongoing pattern of respiratory deterioration, respiratory acidosis, but actually it wasn't reflected in the radiological findings. And despite those changes and really significant escalations in respiratory support, in the stopping of the feeds, in the recommencement of steroids, and the addition of antibiotics over the course of the day, the patient continued to deteriorate. They remained hypoxic, they had ongoing systemic hypotension, and as you see from the blood gas there, despite slight improvement in their CO2, they continued to have this mixed significant acidosis and in fact a worsening metabolic picture. So I was really worried. I was worried because this patient who'd been relatively stable over the course of a number of weeks was having a quite significant acute deterioration over the course of the day. And the physiological parameters would suggest that they were having what looked like progressive worsening sepsis and associated cardiovascular compromise. And yet when I looked at the patient themselves, they actually didn't look too bad. And it seemed to me that that was discrepant with the change in their physiological parameters. So I was both worried about the patient, but also concerned that I didn't really understand exactly what was going on here and what was contributing to this deterioration over the course of the past 12 hours. And at this point, we did a functional echo. And here's a short axis view, ductal view. And you can see here a quite significant change from the echo that we'd taken just 24 hours earlier. Now the ductal shunt is almost exclusively right to left. So there's been a complete flip from a low velocity left to right shunt to a predominantly right to left shunt. And you can see on the PDA Doppler there that there was only a small residual left to right component to the PDA flow. It's predominantly now right to left. So indicating that now the pulmonary artery pressures are suprasystemic or thereabouts. And associated with that, in the apical four-chamber view, you can see that there's a degree of right ventricular dilatation and dysfunction and significant septal dysfunction as well in the 2D loop. Interestingly, with the color Doppler on here, despite the increase in pulmonary artery pressure, there's relatively little tricuspid regurgitation to measure there. I've included tissue Doppler imaging from the right ventricle and from the interventricular septum, really just to reflect the fact that there's an impairment of early diastolic velocities in the right ventricle and potentially also a reduction in systolic velocities and a similar pattern of reduced systolic and diastolic velocities in the interventricular septum, indicating the dysfunction there. So the echo here really helped me to understand what was going on. And this is where I had my aha moment, because things started to make sense now. This patient was having an acute, severe increase in their pulmonary artery pressure. That was promoting a complete reversal of their PDA shunt to one that was now right to left. And clearly that was contributing to their systemic hypoxemia. But what was really striking here was that the associated reduction in pulmonary blood flow was contributing to that increase in CO2. And before we'd done the echo, I was presuming that this was entirely respiratory in origin, but now I understood that it was actually cardiovascular in origin, and that reducing pulmonary blood flow was contributing to this acute increase in CO2. And associated with that, we were seeing the effects of increased right ventricular afterload with associated right ventricular dysfunction. The increase in right ventricular pressures was potentially contributing to reduced coronary blood flow that was exacerbating that dysfunction in the right ventricle and septum. And in combination with the reduced left ventricular filling due to reduced pulmonary blood flow, we were seeing that septal displacement that was possibly contributing to reduced LV filling as well, and combined with the RDV dysfunction, giving a reduced cardiac output picture. And of course, that helped us to explain this evolving clinical picture of lactic acidosis, of end organ dysfunction with oliguria, and potentially also the abdominal distension that we were seeing as well. And it helped us to very much to make a clinical decision in terms of therapeutic option, and we started nitric oxide straight away. And this was the echocardiograms just half an hour after doing that. You can see from the short axis parasternal view on the left-hand panel, that the ductal shunt almost immediately flipped back to a left to right pattern. And you can see that both in the color loop and on the Doppler. And associated with that, on the apical 4-chamber view, you can see that despite the tachycardia, there seems to be an improvement already, even subjectively, in right ventricular free wall function and maybe also in septal function. And that improvement on echocardiogram was also reflected in a wider clinical picture in this patient. Within just half an hour or an hour of starting the nitric oxide, we were able to wean the FiO2 quite aggressively. In fact, we got down to 0.3. The patient's blood pressure improved almost immediately. And the blood gas, strikingly, also improved. You can see that the carbon dioxide in particular started to fall quite acutely, and we had to back off on the high frequency ventilation at this point. And we were already starting to see an improvement in the metabolic component as well. So I was a happy camper. Not only was the patient getting better very quickly, but we had a clear answer as to why they'd been deteriorating over the course of the day, all as it became clear, driven by acute exacerbation of pulmonary hypertension and a nice response to nitric oxide. Over the next day, there was a rise in the CRP, so that helped us to understand why we'd seen this acute deterioration in pulmonary hypertension. It was driven by sepsis. And having introduced that higher dose steroids as part of the escalating treatment plan, the patient actually had quite a significant improvement in the respiratory status and was able to extubate successfully just 72 hours later. And the learning points for me around this case were really about the potential for acute pulmonary hypertensive exacerbation on a background of chronic evolving BPD. I think we recognize that these patients can have a kind of indolent subacute pulmonary hypertensive pattern, but what was slightly atypical here was this acute pulmonary hypertensive episode really around 6 weeks into this patient's course. The other striking thing was the cause was pulmonary hypertension as a cause of acute respiratory acidosis and increased CO2 in this patient. And really the reversal of that with nitric oxide underscored that it was the pulmonary hypertension that was contributing to that. Of course, it also underscored how important functional echocardiography was in making that diagnosis, in understanding the hemodynamics in this patient and helping us to select the therapy, in this case, a pulmonary vasodilator. And the final learning point for me was around this flip in PDA physiology. Just 24 hours beforehand, we were seeing this left to right shunt in the duct, and we were considering the relative contribution of that as a hemodynamically significant left to right shunt to ventilator dependence in this patient. But in the setting of acute pulmonary hypertension, that PDA was almost certainly proving beneficial in terms of offloading the right ventricle, supporting the systemic circulation. And I think just interesting to understand that the PDA physiology can change quite acutely like that. So I hope that was an interesting case for you, and there's similar learning there as well. I'm really interested in your thoughts on it when we get to the Q&A. Thanks very much. I'm going to stop sharing there. Back to you, Mahmoud, I think. Or Anne-Marie. I think Anne-Marie may be taking over.
Yeah. So if you're okay for me to proceed, can you all see that screen view?
Yeah, we can see Anne-Marie.
That's better now, I think. Okay, so I'm just going to echo Neil's comments. It's lovely to be able to join you all from Glasgow. It's a picture of Glasgow Old, our old university, and our new hospital, which is on site on the adult and children's campus, where I work alongside Neil and often Mahmoud. And I want to talk to you about an unusual case of what I'm going to call pulmonary hypertension, but when we have questions and answers later on, you may differ. So this is a little baby born at 24 weeks gestation, a baby girl, a reasonable birth weight, 25th to 50th centile of 592 grams. The pregnancy had been complicated in the second trimester by evolving oligohydramnios that wasn't really understood. And about 3 days prior to delivery, mum had a premature rupture of membranes and developed chorioamnionitis, and she went on into preterm labour and delivered. Now, she was quite well optimised in terms of perinatal management. She had antenatal steroids and magnesium sulfate. And the baby had about 2 minutes of deferred cord clamping on our bedside stabilisation trolley and supported during that period. And APGARs weren't bad at 6 and 9 at 5 minutes, but the baby did have a significant work of breathing and oxygen requirement in labour ward and was intubated and given surfactant in labour ward. And you'll see the X-ray on the right here of the baby after admission with his ET tube and umbilical lines. The lung fields are still quite hazy. There's possibly been some uneven recruitment at the moment, but I do wonder, looking back, if this baby didn't have some evidence of slightly hypoplastic lungs with a sort of a bell shape to the thorax. So perhaps it won't surprise you then to think that this baby had a slightly stormy first 12 hours of life. And the striking feature really was oxygenation difficulty. Initially, they were in 60% in arrival in the neonatal unit, but they graduated up to an FiO2 of 100%. And after it got to 100%, the saturations began to drift into the low 90s and high 80s. And that was despite having a second dose of surfactant at 6 hours, being muscle relaxed and having sedation, was just standardized and conventional ventilation, but interestingly didn't require high pressures, a peak inspiratory pressure of about 18. And there was no difficulty with CO2 clearance, as you'll see from the gases. So this was primarily a problem of oxygenation. In the context of what was a pretty impressive mean arterial blood pressure for a 24-weeker of 30 millimeters of mercury. Despite the setup with sepsis, there wasn't any real evidence. The CRP wasn't elevated, and I can tell that subsequent blood cultures and swabs were all negative. But we had this persistent difficulty with oxygenation. So when I came on at about 8 hours, I decided we'd do a hemodynamic assessment and see what was going on. And I guess before I started, I had 3 main things in my mind. One was maybe it'd be important to exclude critical congenital heart disease. The other was that most likely, given the background, there was severe PPHN with a right to left ductal shunt. And I suppose the third one that's often in my mind is this a little baby with high systemic vascular resistance and a big ductal shunt that might be about to flood its lungs, is even having a pulmonary hemorrhage at this stage, and we might need to think about how we're going to manage that. So I went ahead and looked, and I just started with abdominal scanning and just confirmed that there was normal situs. And I just want to show here, when we looked at the abdominal aorta with the UAC in it. There was colour Doppler on, but it's actually very difficult to see any colour in the celiac or SMA axes. And when I put the Doppler into the celiac axis, you'll see over here that the velocities we got were extremely low. So I was immediately thinking there's something odd about this baby's output at this point, even though we've got a good blood pressure. I next went on just to look at a 4-chamber view, and striking things here, I think, is although we don't have a particularly dilated right side, we've got this bowing of the septum and the foramen ovale over to the left side. And we've probably got what I would say was sort of biventricular dysfunction. The function just didn't look right. At first, possibly worse than the right side. Later on, when I was scanning this baby, possibly worse than the left, with particularly poor septal movement. So that just wasn't right. Just moving on from that view, just angling up slightly, we were able just to catch the left ventricular outflow and drop some Doppler in across the aortic valve. And although it's not a perfect alignment, you can see that the velocities here across the aortic valve were extremely low at less than 0.5 meters per second. So it would again confirm that output isn't good and presumably supports the idea that function isn't good. I then put colour onto the 4-chamber view and got this really striking TR jet, which shoots right across back into the back of the atrial wall, which is either telling us that pulmonary pressures are extremely high, or that the RV is very dysfunctional, or a bit of both, I think would be the most likely scenario when you see this sort of thing. And if you look at the velocity in that tricuspid regurgitation, it goes up to 2.8 meters per second, which would take us to a sort of pulmonary arterial pressures maximum of about 32 millimeters, which would be above our baby's systemic blood pressure, even this baby with high systemic blood pressure. So you would anticipate, therefore, that that would be suprasystemic and we'll get pulmonary hypertension. Then go on and just moved the colour Doppler onto the left side, and actually was struck here that despite the bowing of the PFO into the left atrium, we've also got a TR jet, which has also got quite a significant velocity, even though it may not be quite as striking as the tricuspid regurgitation. Sorry, I think I may have said a TR jet. I meant a mitral regurgitation jet, which is pretty striking and quite a high velocity, even though it may not be quite as large as the TR jet. So that's unusual. We'll now get biventricular dysfunction, but we'll have what looks like a setup for a degree of pulmonary hypertension. Just very quickly, when we're in that 4-chamber plane, looked at some tissue Dopplers, initially at the left and right free walls, so at the right tricuspid annulus and at the left free walls of mitral annulus. And, you know, I think it's difficult in day one. You might suggest that these velocities in systole are quite low, but I think what's maybe more striking is that the early diastolic velocities are low on the right side. But on the left side, systolic and early diastolic velocities look low. But I think what's particularly striking in the septum, that systolic and diastolic velocities really looks pretty low, even for a baby in day one. And we just look at that LV, I just think looking at it, and I know it's very subjective, that ventricular septum just doesn't seem to be moving well. Just moving on from there. We next went to look at the pulmonary circulation. So just looking at the image here, you've got the right ventricular outflow tract with the Doppler just through that. And the Doppler velocities here of the flow across that pulmonary valve are absolutely tiny. I mean, it does look like there's hardly any blood flowing there. And I did wonder if I had some technical problem with the scanner until I switched on the color Doppler, or sorry, the 2D Doppler, and could see that pulmonary valve just looks like it isn't opening. And I did puzzle at that for a while, and I did worry, is this a problem with a degree of critical pulmonary valve stenosis or a variant of pulmonary atresia? But it just seemed a little bit unlikely because we didn't have the sort of anatomical morphology of a big dilated or thickened RV, and those pulmonary vessels, just looking down here at the right pulmonary artery, and I'll show you later the left one, look well developed. But that was very striking and unusual. And I can tell you, in the middle of the night, it did worry me, should I be phoning a cardiologist right now? But persevered, put on the colour, and you can now see, absolutely, there's virtually nothing coming across that pulmonary valve, but there is blood flow from the ductus arteriosus going into the pulmonary circulation. You can see here with this red flash. You can see it also in this one here. So you've now got the nice three-legged stool view, if you like, with the right, left, and the ductus arteriosus. So a sizable unrestricted ductus arteriosus with what looks like almost exclusively a left to right shunt. And just moving on to look at that in a bit more detail. You can see here in this view, again, the left to right shunt, and the Doppler here is quite interesting. It does show continuous left to right flow. It is pulsatile, but it's also a bit unstable, with flow almost falling out completely at times and diastole. So there is, I think, a very critical balance here between the systemic and the pulmonary circulations, with the systemic circulation possibly just having slightly higher pressure than that in the pulmonary vascular bed, which is odd to say that you have got a left to right shunt because of lower pulmonary pressures when you're considering that you've got elevated pulmonary vascular resistance from our previous images. And just moving on, just finally, we just did some post-processing imaging afterwards and just looked for speckle tracking to see if we could learn a little bit more about the function of those ventricles. And we can see that the global strain was reduced both in the left ventricle and the right ventricle. So it just confirms, and it's quite useful to look afterwards, because I think assessments of function can often be very difficult and very subjective. And of course, they are prone to sort of the impact of filling in afterload. So this would suggest again that there was functional impairment. So what on earth is going on? Is this pulmonary hypertension? Everything about the right ventricle tells me classically this is how I see and expect to find pulmonary hypertension. There's RV dysfunction, there's reduced global strain, we've got some abnormal tissue Doppler velocities, and we've got a low right ventricular output. And we'll get very marked tricuspid regurgitation with the pulmonary artery pressures being higher than systemic pressures. And there's a PFO with a right to left shunt, or at least certainly going over to the left side. On the other hand, we've got a left ventricle, which is also showing signs of dysfunction and abnormal velocities with significant MR. An LVO, which is not surprisingly greater than the RVO, reflecting the ductal blood flow, but it's telling you there's not a massive amount of ductal blood flow. But you've got a ductal shunt that is left to right. Typical of that you would see in pulmonary atresia. And I think in this case, we probably had functional pulmonary atresia. So it is unusual, but I would argue we probably did have increased pulmonary vascular resistance in this baby. There is an antenatal setup for it, if you like, with a degree of pulmonary hyperplasia. But there's also RV dysfunction, and that meant it was impossible for the RV to actually generate adequate pressures to get blood into the pulmonary circulation. So our pulmonary circulation became duct dependent, and perhaps we were just slightly lucky in this situation. I'm not sure if that's quite the right turn of phrase, but this baby also had particularly high systemic vascular resistance. It manifested as LV dysfunction, but a highish blood pressure, but that was able just to overcome the degree of pressure in the pulmonary vascular bed and allow blood to get from left to right, albeit at relatively low velocities. And that essentially was keeping this baby alive. There was a very finely balanced situation between that right ventricle and the left ventricle, the systemic and the pulmonary circulations. And I think is that sort of imbalance we sometimes see in babies that have been unwell and just have failed good early transition. So the treatment options I thought for this baby were probably using a pulmonary vasodilator. We did start nitric. Inotropes are an option, but you just have to be careful because you don't want to put up that systemic vascular resistance or systemic blood pressure anymore. So we used a bit of dobutamine and very low dose adrenaline. But equally lusotropic drugs like milrinone would be good choices. I'm sure others would use some other different choices. And I believe at some point, as the blood pressure came down a bit, and we gave the nitric and inotropes, we gave a bit of volume. I suppose the key message for me from this isn't a patient where you should ever rush. Well, this is certainly not a patient where you want to close the ductus arteriosus, and I think you always have to be very cautious if you're thinking about early ductal treatment in these very preterm babies. And I think it's also just very educational about the sort of challenges some babies have around neonatal transition, as their pulmonary vascular resistance and systemic vascular resistance may not fall in the way that we would hope that they would and that the baby requires. And finally, just to show 12 hours later, there was blood flow now into the pulmonary circulation and the duct is starting to close. So there wasn't a pulmonary atresia, and I was glad to see that that was the case. And this is the baby a week later, got normal blood flow now across the pulmonary valve and the duct is completely closed. So from that side of things, all ended well. Although I would say that sadly the outcome here was that this baby died of intractable respiratory failure 3 weeks or 4 weeks later. Perhaps that could have been predicted from some of these early hemodynamic images, but that's a whole other topic. So thank you, and that's my case. And I look forward to talking about it later on and seeing if others agree that this was pulmonary hypertension, or if there's perhaps another explanation for the sort of unusual hemodynamic findings. Thank you.
Thanks, Anne-Marie. Hi, everyone. I'm just going to share my slides. Can you see that?
Yes.
Perfect.
Perfect, thank you. Right, so I'm just going to share another case, slightly different from Neil and Anne-Marie. So that was a term baby, born by emergency C-section because of concerns over growth, requires some support with CPAP, but actually we noted that the FiO2 requirement was persistently going up. He was transferred to neonatal unit on CPAP of 7 centimeters in 65% of oxygen. So in terms of bedside assessment, these were kind of his vital signs. He was mildly tachypnic, not actually what we'd expect with this degree of oxygen requirement, had a bit of tachycardia, no recessions, no increased work of breathing, and saturations were kind of high 80s, low 90s, and cap refill was around 2 seconds. There were no pre and post ductal sats difference. Blood pressure was okay for his gestation. and this was the first CAP gas, which showed mild respiratory acidosis, no metabolic acidosis. So baby had septic screen done, started IV antibiotics, and we were waiting for the chest X-ray, but they were quite busy in A&E, so I decided to perform a lung ultrasound. I'm just going to quickly give a brief overview of lung ultrasound because I'm lung ultrasound enthusiast, and that you will understand in the next few slides why I'm bringing this up. So just to remind people, just a quick summary. These are the kind of lung ultrasound zones that we do. So we divide right side into upper, lower, and lateral, same on the left sides, as suggested by Rosalind Bratt and her group. And this is from Yasser Said and his group as well. So just you understand the annotations. Normal lung ultrasound essentially looks, oh, sorry, I want to play the video. Here you go. So you can see the skin subcutaneous tissue, and that's a cross section of the ribs. This is a pleural line, and this is the most important thing you want to comment on. That's nice, thin, crisp pleural line moving nicely, creating what we call reverberation artifacts or the A-lines. And this is a normal lung ultrasound pattern with a well-aerated lung. If you have fluids, interstitial fluids, what you will start to see is the B lines here. So these are vertical lines arising from the pleura going down, and these could be either separate or coalescent depending on the amount of interstitial fluid. If you have RDS, what you will find is more coalescent B lines, and then the pleural line will be more irregular, and you might find small subpleural consolidation, and that pattern is consistent with RDS. Then when you use a scoring system, this is a normal lung ultrasound, so this is score 0. If you have mild interstitial fluid, more than 3 separate B lines, then that's score 1. If you have more coalescent B lines all over and no A lines seen at all, that's score 2. And then if you have more severe interstitial syndrome with air bronchogram and consolidation and thickened pleura, that's score 3, which is the maximum. So we have maximum score of 18 depending on what you find on the 6 lung zones. So back to our case. So this is the right side upper zone. You can see pleura is fine. There is some A lines, but lots of B lines, but it's not completely coalescent. And you can see it's more condensed during expiration because alveoli just collapses. And then this is R2, the lower lung zone on the right side, pretty similar. And then when you go to the lateral side, it's more clear that this is more condensed B lines, thickened pleural line, and subpleural consolidation. The left side was pretty similar on the anterior left lung, upper and lower. You can see B lines, not very coalescent, and you can see some A lines in the background. Same on the lower left side, but however, the lateral side was more condensed and coalescent. So just scoring this actually gave me a score of 9. And we know from literature, from Professor Raimondi and his colleagues, and also from our colleagues in Canada, that above 8, the curve, the area around the curve predicts good response to surfactant. So this is just gave me an impression. This is probably mild to moderate RDS, but it didn't make sense to me why the baby is requiring that much oxygen. So now we're just going to bring some questions for the audience to answer, but this is just show you the X-ray after we did it, which looks like probably mild to moderate RDS, but didn't explain the amount of oxygen that the baby was on. So can we bring the poll, please? Thank you. So what would you do next? Intubation, ventilation, and surfactant, or the same plus nitric? Or would you perform some kind of hemodynamic assessment before nitric? Or would you do something different, like non-invasive surfactant, for example? And just give a few seconds. Great, thank you. Right, perfect. You all agree that we need to give some surfactant, and then you agreed also we need to do some kind of hemodynamic assessment. Okay, let's see. Sorry, I'm just trying to. All right, I will just show you. I decided just to do echo and a hemodynamic assessment to see is there any underlying pulmonary hypertension, why the baby is requiring that much oxygen. So this is the 4-chamber view, and strikingly you can see that right ventricle is hugely dilated with the right atrium. The septum is flattened, and you can actually argue it's probably bobbing to the left. And the left side is quite small, both left ventricle and left atrium. And with colored Doppler on, you can see good going TR jet as well, indicating there is increased pulmonary vascular resistance. Sorry, we just go back. And this is a 4-chamber sweep. You can see the LVOT and also the RVOT, so it's not TTA, but you can see that the LVOT, the ascending aorta is quite small as well. And this is a ductal view, and you can see the duct here is bidirectional, and this by pulse Doppler confirmed. It's actually mainly right to left, indicating there is increased pulmonary vascular resistance. Now, we'll go to the second poll, please, Laura. So you have this initial images by echo, which looks like there is pulmonary hypertension. What would you like to know more from the echo? Assess LV function or structure assessment, including LVOT, to rule out LVOT obstruction and look at pulmonary veins, rule out significant extracardiac shunt, all of the above, or something different. Thank you. All of the above, okay, great. I will just move on. This is a arch view, and you can see nice flow through the arch, no evidence of coarctation or interrupted arch. And then this is a subcostal view showing the IVC normally connected to RA, and the normal hepatic vein, and the aortic, abdominal aorta as well is seen. So no kind of evidence of extracardiac shunt in the liver. Subcostal view here, you can see actually a quite dilated SVC, and the blood through the PFO is strikingly right to left, and which it was confirmed. So it's purely right to left flow through the PFO. So what's going on here? And this was kind of really alarming signal to me. So I swept from the subcostal view, and what you can actually see here, this is a dilated, as you see, the red flow. But you can see above, or like posterior to the both atria, you can see a transverse dilated vessel, which you shouldn't, that's not normal. So you shouldn't see that in normal anatomy. So there was something going on here. So that was SVC and a kind of transverse vein connected to it. So I immediately went to suprasternal notch and looked at trying to find the pulmonary veins. And what you can see here, the blue jet here, that's the SVC, which is dilated. but also you can see the transverse vein or the connecting vein draining blood into the SVC, and I couldn't see any pulmonary veins. So this was simply a supracardiac TPVD. So for this case, in terms of management, that we have to be just think about the pathophysiology, and do we actually need to use nitric? Would nitric help, or actually it's probably not a good idea? So I will come to that in a second, but just to kind of remind people about different types of TPVD. So this is the type of our case, supracardiac. So essentially, pulmonary veins are not connected to the LV, but they are both connected like to a venous confluence at the back of both atria. There is an ascending vein and transverse vein, and then the transverse vein will drain into SVC, into the right atrium, and then back to the lungs. So there will be a mixture of oxygenation here. The cardiac type, the veins will be connected to a confluence that will drain into the coronary sinus. And then the infracardiac is essentially connected to the inferior vena cava through the liver. And the mixed is just a combination of all. So what's happening in kind of hemodynamics for the TPVD? So essentially, because no connection of pulmonary veins to left atrium, all oxygenated blood will go to from the lungs to join the SVC via the transverse vein or the connecting vein. Then mixing of blood will happen in the SVC, and then the mixed blood will go back to the right atrium. Most of it will go down to the right ventricle, back to the lungs, so there will be increased pulmonary blood flow. However, depending on the pressure inside the right ventricle and also the size of the PFO or ASD, an amount of blood will go from the right atrium to the left atrium, and that's the systemic supply, because there is no other way the left side will get blood. And that's why the left side on echo was quite small, because no much blood going through that. So increased blood flow will cause two things. Will cause pulmonary venous congestion leading to edema, and also will cause pulmonary hypertension driven by the increased flow, not by the pulmonary vasoconstriction. And that's why when we use nitric here, it's not gonna help actually. So systemic blood supply, as we said, will be depending on the size of the PFO and PDA as well. However, things can get worse if obstruction happens. And there are two possible sites for obstruction, either at the junction between the connecting vein and the SVC, also at the site of the PFO if it starts constricting. So if this happens, what will happen is that severe pulmonary edema and shock, because there is no enough blood going to the systemic circulation, so reduced cardiac output and shock, but equally, the blood will be more shunted to the lungs, causing more edema and more pulmonary hypertension. That's why we don't advise to start nitric here, because nitric actually will end up in reducing the pulmonary vascular resistance, making pressure difference from the right ventricle to drive more blood to the lungs, and increasing the blood flow, and then the vicious circle will just keep continuing. And this will probably lead to high risk of obstruction, because the velocity of the blood and the volume of the blood coming in the connecting vein will face the resistance from the IVC, and that cause more obstruction to happen. And that's why we don't advise using nitric in this case. So just to show you this baby, actually, this blue jet here is the SVC, and that's a transverse vein, and this is a connection. And you can see here the velocity of the blood at the junction, which was high. So this baby had a moderate obstruction. So what happened? We ventilated the baby given surfactant, and that actually helped the FiO2 to come down. We didn't commence nitric. Central line obtained. Obviously, this baby was discussed with cardiology team and transferred by neonatal retrieval system team to go there. Diagnosis was confirmed by formal echo there and also CT angio. Went to surgery next day, recovered well, and discharged home. So I suppose the learning points here, we need to think about lung and heart axis in neonatal disease rather than looking separately at the lung and the heart, because they both talk to each other. And for this particular case, I was alarmed by doing the lung ultrasound that actually didn't match the FiO2 requirement. So I wanted to look why the baby is needing this much oxygen, and that prompted me to do the functional assessment. And while doing the functional assessment, actually, you need to make sure you're not missing any structure abnormality as well. And also you need, when you do the functional assessment, you just have to try to look what are the causes of the increased pulmonary pressure. Is it flow driven, increased blood flow, or it is because of the increased vascular resistance and its vascular bed problems. And finally, the patent ductus in a typical pulmonary hypertensive state, we need to understand what's the pathophysiology underlying, and for example, Neil's case and Anne-Marie's case were quite different. And thank you very much. We'll be happy to take questions.
So thank you so much to our speakers for your excellent presentations and giving us a flavor of the different types of cases that you guys are seeing. I'd like to invite our panelists and speakers to join us for this open dialogue and discussion. And also for a reminder for our audience, if you could type in the Q&A, any of your questions. If we're not able to answer all of the questions, we'll make sure to type up the answers and get them back to you guys out in a different format. So just to get things started, one of the things that really came across to me in all three of your talks is the utility of using neonatal echo and lung ultrasound to better understand and evaluate what's happening with these babies on a minute-to-minute or serial nature. Can you speak a little bit to, is that a standard across your unit with all of the neonatologists have this approach? You still rely heavily on some of that, outside resources for standardized echo, or how do you guys approaching that?
Thanks, Lauren. That's a very interesting question. And I suppose lung ultrasound, I know it's widely used across Canada in many centers, and also across Europe in other countries. It's relatively new in the UK, I have to say. So we're trying to spread the knowledge about it here. But it's not widely used. So I suppose it's a skill. I feel it is quite useful at bedside, just to help make decisions and give you more information. But it's still in the process of trying to implement it in a proper way, under proper governance structure, etc., etc. So we're doing some work on that, but it's not widely used at the moment.
And is neonatal echo a standard throughout the centers, done by neonatologists to just have a more kind of neonatal hemodynamics consultation similar to the ones that you guys just presented in these cases?
Anne-Marie probably can answer that.
I'm sorry, Lauren, can you repeat that again? I'm slightly distracted by some of the chat as well.
Oh, no worries. I was just wondering, in the States, targeted neonatal echo is not a standard practice, although we're reading a lot more about different centers that are utilizing this. And there's certainly some centers in the States that are using this practice. And one of the things that was a really take home for me listening to all three of your cases was how valuable it was for you to be able to assess physiology in that kind of way. Just wondering if that is a standard practice in your unit.
Yeah. So I think Nim will come in this as well, because he's obviously got a long history of neonatal echocardiography and expertise in Liverpool. But yeah, I think it's been steadily growing for a long time. So it's by no means absolutely standard, but I think most neonatal units or most of our bigger neonatal centres are focusing on taking the very small preterm infants, are developing interests in a fairly standardised approach to neonatal echocardiography. But it's we don't have necessarily the formal training system that's established in the States, or people employed full time to do it. So it is very much neonatologists of an interest and trying to develop clinical governance and accreditation around it.
Thank you. And I see a hand from one of our panelists.
Yes, hi, thanks very much. Perhaps I can just answer that question from a Liverpool perspective. That in the UK, I think there was a survey done a few years ago which suggested that over 75% of neonatal units had a neonatologist who was interested in and had the expertise to perform functional echocardiography. The problem is that in the UK, neonatal care is organised in a slightly different way, I suspect, to many other countries, where many of our centres, including Liverpool, we don't have children's services and a paediatric cardiologist on site. So it's almost evolved into neonatologists being interested in functional echocardiography almost out of necessity, because there's no one else to perform echocardiography for us. So the short answer is many neonatal units have at least one person, usually more than one person, who's able to do functional echocardiography. What limits our care and application of echocardiography is that we don't have round-the-clock expertise and access to functional echocardiography. So you may have someone who's interested, who does an assessment, a functional assessment, starts a treatment, but those important serial assessments after that, over the next 24 hours, for example, that we may not have access to that. So it's pretty sporadic and patchy, the sort of expertise we have available, but certainly there's a momentum and there's gaining interest in acquiring that skill, I think it's fair to say.
Thank you. And one of the questions from the audience is regarding, from Dr. DeWall, regarding the presented cases. There's a lot of discussion on the heart function, but expressed more subjectively. And so what are the thoughts in the group, and also kind of trying to take advantage of meetings of this nature to talk about things in a more objective fashion, objective values for LVO or RVO? What are some of the advantages or limitations of using that approach?
Maybe I can come in there. I think Kurt makes a really good point that as a group within NHRC, if we want to move forward the ability to discuss these patients and to truly understand the pathophysiology, we should be more specific about exactly what we're measuring and the quantitative nature of that. I think we've all grown up with the perhaps more cardiological based qualitative assessment of cardiac function, and I don't dismiss it. I think experienced echocardiographers are able to look at 2D loops and discern quite a lot from that in terms of function and pathophysiology. But I think it's a really good point that we should perhaps in the future, including myself, look to present quantitative data as well. As Kurt also points out, however, there are challenges around the vendor-specific parameters, particularly when it comes to things like strain analysis and speckle tracking interpretation, although hopefully the vendors are working towards more consistency around that. And of course, the other numbers, including ventricular outputs, are prone to degree of measurement error as well. But I think it's a really good point that we should move away from solely qualitative kind of discussion and work towards normalization of the quantitative measures in our discussion and kind of clinical management.
I was just going to follow on, Neil. I agree with you, like in terms of using the quantitative measures, and I suppose following on from that first question, in terms of using your echocardiography assessment, in terms of the clinical setting as well, that we should be using those measurements, and I suppose there's momentum in using them as well. That more and more people are becoming more familiar with them, and the more we use them, people do get to know them as well. I think Anne-Marie was going to say.
I mean, just a comment that, I often try and now report any of our ductal assessments unit in a very standardised, structured way with measurements and scores. There's a number of different systems you can use that rely on taking a number of different measures that are as standardised across different services as we can get at the moment. And I think the clinical team like that, and they value that, and they feel it's much more reliable, and it also gets that interest. So it's certainly one of the things we're aiming to do is to have much more standardised reporting. I know that Neil does do a great amount of detailed analysis though of all of his pulmonary hypertension work offline.
Thank you. And just to expand a little bit on the ductus, there were several comments and questions about the PDA, and there's an advantage to keeping it open in some cases, and then it becomes more pathologic if it stays open, and just the utility that you guys are using for your serial measurements. Is there any kind of quantitative way that your groups are looking at the ductus to help guide when is the time to use prostans to keep it open, and when is the time that you need to use things like Indocin or Tylenol to try to close it, and recognizing that there's different time points in different babies?
I can speak very briefly about when I try and keep it open, if that's useful. So excluding the babies who have structural heart disease and clearly a duct-dependent, circulation, putting them to the side, and actually that interesting case that Anne-Marie presented, which was one of functional duct dependence, possibly. I think in the setting of classic pulmonary hypertension, to me, the three criteria I used in my simple mind to decide when I need to keep the duct open are, firstly, is the pulmonary artery pressure systemic or suprasystemic? So am I getting a sense of that from a predominantly right to left or shunt in a duct? Secondly, is the duct itself closing? Because clearly if it's nice and wide open itself, then I can just monitor it. I don't need to keep it open. And thirdly, what's the right ventricle looking like? If we've objectively and quantitatively got evidence of right ventricular dysfunction, then to me, that's another indicator to keep the duct open. So I look for those three criteria. If they're all present, that's when I would start prostaglandin. And then I would continue to monitor quite closely. And once the ductal shunt starts to reverse, then back off on the prostaglandin. So I think, as if nothing else, what it is a targeted neonatal echocardiographic assessment of the circulation and a decision based on that. But in terms of when to close the duct, I would definitely bow to the knowledge of Anne-Marie on that one.
I don't know, I'm sure there are other people in the forum who could certainly talk to that. But for our practice, we certainly focus on closing the duct on babies under 28 weeks gestation. We tend to, or aim to look at them in the first 12, 24 hours of life, but not really for view to closing the duct, really just about learning about what's happening with those transitional circulations and trying to learn if there's a group of babies where the circulation may be unbalanced in a way that might lead to pulmonary hemorrhage. But that's really a part of our practice we're evolving. I guess our sort of clinical practice would be for those babies around about days 3 to 5, they'll get a hemodynamic PDA assessment. And I tend to use the sort of really the kind of I'm calling them North American scoring systems, though I realise that they were developed by people who work in different centres around the world, including Afif, who's in Dublin now, Patrick he was in Toronto, who's now in Iowa, looking at a balance of measures, really looking at the duct itself, looking at its diameter and Doppler, but also looking at the impact on the LV, the impact on the systemic circulation, the impact on the pulmonary circulation measured by pulmonary venous drainage, etc. So I need to, I guess, have quite clear and definite markers of an impact in all of those areas. And those babies will certainly consider closing the duct early on in the first week of life. For us, usually with ibuprofen, prefer that to paracetamol or Tylenol. But, you know, indomethacin got a really interesting and slightly different role to play, I think, in some of these very small babies at risk of very early big pulmonary hemorrhage and intraventricular hemorrhage. So, yeah, so we try and get a very balanced approach, and then we will weigh take the echo findings and balance them against the clinical findings. But if there is what I would call a moderate large duct using all of those measures, we would probably treat it. And that may or may not be the right thing to do, but that's our current approach.
I see that Elaine and Daniel, you both have their little hands.
I was just going to agree with Anne-Marie that that's a very similar approach that we do in Liverpool, that we assess for hemodynamic significance of the duct before we decide to treat it.
A quick question on what we were discussing, that it is difficult to have a T&E person around the clock and you're doing long ultrasound. And do you have a specific protocol, like a cardiac focus and lung? What we're trying to do is that all our fellows are competent on lung ultrasound, and they can do a basic cardiac evaluation in order to engage either with cardiology or with us. Do you have any experience on a protocol like the SAFE protocol or something to ensure that the advantage of the ultrasound is there on call?
I might answer that, Daniel. So that's again work in progress. I don't know if you noticed during the introduction, we're just forming a group of interested people in neonatal hemodynamic dynamics and POCUS across the UK, and we're inviting people who are interested to join us. So there are lots of work in progress. Regarding the lung ultrasound, there are people who are interested, and we are encouraging to implement in their centres. And there is a guideline being developed as we speak, so hopefully will be published soon. With regards to echo and cardiac assessment, again, there is some work going on training syllabus and curriculum for training people who are interested, just to have this developed as well, because I think it's quite useful skill at bedside to have both the skill to do lung ultrasound and echo. It just gives you another depth of information, and that definitely help to understand what's happening with the baby.
And Nim, I see your hand.
Thank you very much. I hope we've got enough time for a few questions about the cases, because the cases were absolutely fascinating. I really enjoyed them. Thank you very much. My question is going to be to Anne-Marie. Two questions, Anne-Marie. One, you almost invited this question in your introduction about whether we thought this was pulmonary hypertension or not. So two questions really. One for you is, one, what would be your definition of pulmonary hypertension? I noticed you said that the estimated pulmonary pressures were suprasystemic, and although the systemic pressure didn't seem that high, you said that it was the pulmonary pressure was suprasystemic, and therefore it was pulmonary hypertension. So I'd like to ask you one about that, and secondly, about whether you thought this really was a pulmonary vascular problem, an increased pulmonary vascular resistance primarily. I would have said it was biventricular dysfunction, an RV dysfunction resulting in poor pulmonary blood flow. and therefore the duct is supporting pulmonary blood flow. Well, I wonder what your comments on that were.
Yeah, I've thought about this quite a lot and gone round in circles now. And, you know, I don't know if the severe biventricular dysfunction was due to abnormal elevation of the pulmonary vascular resistance, the same systemically. You know, this baby did have a high blood pressure, and we do see small neonates with high-ish blood pressures are actually failed transition. They're abnormally high systemic vascular resistance, and they're struggling, and it results in LV dysfunction. So there is that argument, this is biventricular dysfunction, but what's causing it is innate to being preterm and some other physiological disturbance. We didn't have evidence of sepsis, but maybe there was sepsis, or is it a response to the vascular resistance? And I'm not sure that I'll, you know, ever actually get the answer to that, but technically I would have said if we've got suprasystemic pulmonary pressures, it is pulmonary hypertension. But then you see a left to right shunt and you think, what does that mean? But if I had seen a baby with pulmonary hypertension, the classic right to left shunt at the duct, I would probably have raised the systemic blood pressure till I got something like that sort of picture we had, not with the biventricular dysfunction, but the ductal shunt going right to left. So maybe in a way this baby's pathology had sort of balanced the problem. But I deliberately said it's a case of pulmonary hypertension in inverted commas, because I wasn't quite sure, and I don't know that there's a way of really knowing what that baby's pulmonary vascular resistance was. And we often get this if you have severe ventricular dysfunction, you can't really estimate the pulmonary pressures. But it was curious to get the shunt at the atrial level, the reverse the shunt at the ductal level. I mean, I'd be interested in anyone else's thoughts, but I do think you're absolutely right. I think the ventricular dysfunction was important, and it's probably, I suspect it was multifactorial.
I think I totally agree with Anne-Marie. We've been talking about this case actually while we've all been preparing our cases and thinking about them. And just a wider point, I think that is something that I've come to appreciate is in neonatology, historically, we've talked about pulmonary hypertension and in the isolation, really, I think of this acute transitional problem of what we call PPHN. And I would argue that actually that perhaps that's a concept that we should move away from, because to me, PPHN describes a clinical phenotype, hypoxic respiratory failure, effectively often with systemic hypotension. But actually the underlying mechanisms that can lead to that clinical presentation can be so variable. And I think all of us who are interested in functional echocardiography and hemodynamics have had that education of, you know, realizing that there's many different variations on the actual nature of what the pulmonary vascular resistance is, what the cardiac function is, what the ventricular outputs are that contribute to that syndrome of PPHN. And I think in the future, maybe what we'll do is better describe these patients in terms of their pathophysiological phenotype, rather than this overarching pulmonary hypertension label that we tend to ascribe to them.
I couldn't agree more with trying to move away from that distinction and talk more about actually understanding what the underlying cause is. And I think that'll help us design trials and study these patients too, if we can group them based on what their actual pathophysiology is. I think we have time for one more question if anyone has any questions about other cases that were presented, and then we'll wrap up.
If I can comment, please, Lauren, just because in the poll results, there was some comments about non-invasive surfactant for my case. And I think probably it did cross my mind when I was at the bedside of the baby, but the reason I wasn't quite keen to do it because of the FI2 was really, really high. And for those kind of near-term to term babies with this significant amount of oxygen, it's not simply RDS, especially the more you are towards term gestation. There is usually an underlying combined pathology, either PPHN or something else. And I think we just need to be careful not to treat this as a pure RDS. And that's the beauty about using lung ultrasound and echo at the same time, is just to give you more information about both heart and lung together.
Well, thank you all so much for your time and your conversation and your expertise on these topics. I realize that there's a couple of questions that we weren't able to get to in the chat box, and so we will answer those and put them in a document on the NHRC Twitter page so that people can continue to have these conversations. But thank you again. I really appreciate everyone's time and putting these cases together, and thank you for the audience as well.
Thank you for having us.
Thank you. Our pleasure.
Thank you.